Thank you very much. I would now like to invite Dr. Shastri up to the stage to present updates on MDS.
Thank you. Hi, everybody, and good morning. So to carry on the theme of myeloid malignancies, have a case. I will be talking about myelodysplastic syndromes and some significant updates in the field. Sorry, my pointer is, okay. All right, okay. Sorry, I don't. Okay. Okay, I'm gonna wait. Sorry, I'm being a little impatient I guess I have an early flight out, so. Yeah. Okay, thank you so much. Okay, hi everyone, and it's such a pleasure to be here with you in Vail. These are my disclosures. And before we start, I just want to say that, for the not so enthusiastic about like cold weather, Vail is really beautiful in the summer, and I had a pleasure to come here in 2016, and I hope I can come back again because this is such a beautiful place to have this nice event. So I'm going to go over sort of a little bit of an overview of how we think about treating MDS right now, along with significant updates in the last 2 years. So as we know, this is a hematopoietic neoplasm considered in the realm of bone marrow failure with cytopenias that we can see by the clonality that it shows in terms of cytogenetic abnormalities, somatic gene mutations. The dysplastic morphology is the hallmark of the disease, and 30% of patients will progress to AML. Although the annual incidence captured in the US, through like these SEER type-based registries puts it in the realm of maybe a rare disease, if you look at more population-based registries, it does appear that MDS is very common. We have lots of patients out there in the community that may be undiagnosed. And it's a disease of older age with a median age of presentation of about 71 years. So this is something that we wrote a few years ago, but essentially, are low-risk MDS and high-risk MDS similar or different? Is it a continuum or a spectrum that goes on all the way to AML? Well, one way to think about it is that low-risk MDS is actually a state of differentiation arrest, which is exactly what we see. We see cytopenias, we see anemia, thrombocytopenia, and a lot of the effort in terms of therapeutics in this space have been put towards overcoming this type of differentiation arrest that we see in low-risk MDS, whereas high-risk MDS is really expansion of certain stem and progenitor compartments, which actually contribute to the high number of blasts that we see and a more AML-like state. So not surprisingly, the treatments or the newer agents directed in this space have been sort of directed towards preventing the progression of high-risk MDS to AML. So what are some key updates for MDS in 2022 that we're continuing into 2023? Well, we have updated classification systems, and we have a new prognostic scoring system, the IPSSM. For low-risk MDS, I will go over some updates in terms of the medalist data with luspatercept, Sintra-Rev, which looked at low-dose lenalidomide preventing progression towards transfusion-dependent anemia, a quick update on a novel telomerase inhibitor, Imtelstat. And in high-risk MDS, I will touch upon the Venetoclax and azacitidine combination, as well as some updates with newer agents such as magrolimab and the IRAK4 inhibitor. So one of the interesting things that happened for us in MDS was, we have a new prognostic scoring system now, and therapeutic development has really accelerated with the FDA approval of luspatercept, as well as Inqovi in 2020. So this is kind of the updated 5th edition for the WHO. MDS is now the myelodysplastic neoplasm, which acknowledges that it's kind of a cancer, of course. And the morphologic dysplasia qualifier is now omitted. We don't have this MDS unclassifiable, and we really have a stronger definition in terms of cytogenetics as well as molecular abnormalities that we see, primarily the del5q, SF3B1, and TP53. To make matters even more confusing, the ICC also updated the classification. And while we see some similarities here, we see some differences here. What they call the EB2 or the IB2, which has more than 10% blasts, is now considered AML. So technically, you could say that 10% blasts and more is in the realm of AML, and you could make a justification for AML-based therapies for these patients. So as we know, the IPSS was our first tool for risk stratifying MDS, and the prognostic variables we used were bone marrow blast, the karyotype, and cytopenias. This was better refined by adding more cytogenetic data and further risk stratifying it from a very low to a very high risk category for the IPSS revised, which again gave us a better way to prognosticate our patients in terms of overall survival and time to AML evolution. But now we're seeing that the genomics of the disease are becoming really important in how we prognosticate our patients, how we give them information about how aggressive their disease is and how likely to progress to AML. And some of the important players in this space are obviously the splicing factor mutations like SF3B1 and the sort of other co-mutations in that space, as well as these mutations that regulate the epigenetics such as TET2, ASXL1. Yeah. So yeah, I agree with Dr. Deininger. This pointer is is really suffering today. Yeah, so as we can see, this is not just a lot of jargon. I mean, these mutations, as they pile up, as you have 1 to all the way to 5 or 6, you actually have worse survival as these mutations pile up, with the exception of having SF3B1, which is actually considered to be a good prognostic factor in MDS. And these somatic gene mutations actually improve the precision of the prognostic systems we have. So fast forwarding now to the past few years, we can see that in the past 2 years alone, we talked about this a little, the SF3B1 is linked to more favorable outcomes in terms of overall survival. And this sort of, the phenotype of the disease is very closely associated with pathologic findings of ringed sideroblast, ineffective erythropoiesis, and has a very indolent course of disease usually, and platelets and white blood cell counts are usually normal. Whereas if you look at TP53, this is again a very interesting and problematic mutation for patients with MDS. So what is kind of interesting is that patients that have monoallelic TP53, that is just one mutation in TP53, have a much better outcome than patients that have more than that have this sort of multi-hit TP53. And this is not very, very well understood, but if you tie it all in together, it may explain why, patients with del5q and MDS overall do better. And so this is kind of interesting. And so because of all this myriad of molecular findings that we have now, we have a new prognostic system, the IPSSM. So the way that the IPSSM was developed was that almost 3,000 patients with the genomic alterations, this was a curated genomic data set, and then there was a validation cohort from Japan, and there were significant mutations that were picked out that were prognostic and added into the sort of IPSS. And some of the ones that are modulated by pattern of co-mutation are your TP53, FLT3, and MLL. And so it resulted in a risk score using mutation, cytogenetics, hematologic parameters, and we do think that it has improved the prognostic discrimination for patients all across the different risk categories. It's actually really easy to use. So if you Google it, like there's a web-based risk calculator. I have been using it in clinic, and it allows you, it's a little cumbersome in the sense you have to spend the time to actually plug in all the information. But once you do, it kind of gives you a nice sort of graphic representation, as well as tells you which risk category your patient might be in. And I think in some ways I find this helpful to actually have conversations with patients and show them this data, tell them where they're on at the curve, and what treatments we could potentially offer them. So let's talk about what are our current treatment options now for low-risk MDS as well as high-risk MDS. We will go through some of these options for low-risk MDS now. So ESAs, so the ESAs still stand strong, in this age of targeted therapies. And these are important drugs, epoetin alpha and darbepoetin. They do improve anemia, and they do reduce the need for transfusion, improve the quality of life. In some cases, and I will show you where there is sort of like non-responsiveness to just the ESA, you could actually add in a myeloid growth factor, and you may see that patients may respond when you do this, especially in those that have lower EPO levels and more than 15% ring sideroblast. And the ESA regimens can definitely be adjusted in terms of dosage to maintain RBC transfusion independence. And so, this German group led by Dr. Kubash have actually also come up with a scoring system for predicting responsiveness to ESA-based therapies. And this is, again, you can just look at the sort of the level of the EPO level and the transfusion units that your patient is receiving. This is helpful in the sense that it helps you realize which patients might have a good response to EPO versus who might not have a good response, because unfortunately the primary resistance is quite frequent, and patients do ultimately stop responding to EPO, which is an issue we still see. Now, the current NCCN recommendations say that, if your serum EPO level is less than 500, right, so you could still treat EPO, and you can kind of go up on the dose, from 40,000 to 60,000 units. You can add in the myeloid growth factors, as we talked about. You can switch it up to darbepoetin alpha. If you don't see a response by doing all of this, you go on to second-line luspatercept. If the serum EPO levels are already very high, you can actually kind of consider luspatercept, and luspatercept may be even moving up to like frontline here in the serum EPO low arm, so we'll talk about that just a little bit. If you don't see a response with luspatercept here, you can consider lenalidomide, because even in del(5q) negative MDS patients, a small subset do respond to lenalidomide. Okay, so going into the biology of luspatercept, now how this drug was developed. So as we talked about, low-risk MDS is really a state of differentiation arrest. And in the case of the erythroid development, what we see is that this terminal erythroid differentiation is arrested. And this is because there is this very high level of inflammation in the bone marrow microenvironment, mediated by the TGF family, beta superfamily. And luspatercept is actually a drug which is considered to be a ligand trap, and it sort of releases this maturation block, and it allows these kind of erythroid precursors to ultimately differentiate and form normal red cells. So this is kind of the structure of the molecule. It's a modified activin receptor and the Fc of a human IgG1, and it inhibits SMAD2 and 3 signaling. It actually traps GDF8, 11, and activin B and stimulates RBC production. So the Medalist was a study that actually looked at patients with MDS with ring sideroblast that kind of were transfusion dependent, and randomized the patients to getting luspatercept versus placebo. The dosing of this drug is actually quite convenient. It's once every 3 weeks, and you can actually increase the dose as well if they're not responding to the first dose that you start. The one issue that I have faced with my patients and was in the study as well, and shouldn't be underestimated, is fatigue. So people can have pretty severe fatigue actually on luspatercept, and in a couple of cases I've actually had to discontinue the drug because of fatigue. But most of the times, otherwise it doesn't have too many side effects and seems to be pretty well tolerated. So in this particular study, 38% of the patients met the primary endpoint of transfusion independence for 8 weeks or longer, compared to 13% of those in the placebo group. And the median duration of response is about 30 weeks. There was actually an ASH update which showed that there was more longer-term evidence that confirmed substantial reduction in the transfusion burden with luspatercept. And this was actually retained after a median follow-up of 26 months. So further updates is that even though the study wasn't really powered to assess overall survival, it does appear that it may increase probability of OS. And the 36-month OS probability was increased for patients with IPSSR, a very low-risk MDS, and for patients with lower EPO levels, which then brings us into this phase 3 COMMANDS trial, which has actually looked at luspatercept as frontline head-to-head comparison with epoetin alpha in ESA-naive low-risk patients with anemia that need a RBC transfusion independence, that require RBC transfusion, And the press release has actually shown that the trial is positive, and we're waiting on the publication of this data. So that's encouraging. We could actually use this more frontline now, it looks like. So lenalidomide, so this is also a tried and tested drug for us here in MDS, especially for the del(5q) subset of patients that respond very well to lenalidomide. And so it continues to obviously be approved for the management of transfusion-dependent anemia due to low intermediate risk del(5q) MDS, whether it's standalone or with other additional mutations. And as I said, in the algorithm, you could use it if nothing else works. Now, I want to highlight this study, which I thought was very interesting and provocative and presented at ASH this year. This was the final update from the Sintra Rev1 study from Spain. And what they were actually looking at was, the question was, could we give a lower dose of lenalidomide continuously to patients that are not yet transfusion dependent, so those that have anemia, but they're not yet transfusion dependent, so as to prolong the time to RBC transfusion need. And so this is the way the study was done. It was a phase 3 multicenter study. They gave lenalidomide 5 milligrams per day continuously versus placebo. And after 2 years of treatment, there was 2 years of follow-up. And what the study actually confirmed, which is interesting, is that low-dose len did prolong the time to transfusion dependence from the beginning of treatment. It improved hemoglobin levels. And what I found was very interesting was it actually induced cytogenetic responses. So this kind of brings us in the realm of a little bit of preventative care for MDS. And we could ask the question that, well, can we prevent even our low-risk patients from progressing to getting transfusions? So we have some new drugs and activity in this space. One of the promising agents in low-risk MDS is Imtelstat. So Imtelstat is an oligonucleotide. It is a competitive telomerase enzyme inhibitor that binds and blocks this active site of the enzyme. And there is data to show that it selectively targets malignant cells that have this continuously upregulated telomerase. It induces their apoptosis and enables potential recovery of normal hematopoiesis. So there was phase 2 data that was reported that actually showed that this particular drug was quite effective in RBC transfusion-dependent patients that were ESA relapsed or refractory low-risk MDS, and it did induce a meaningful and durable transfusion independence rate. And the 8-week and 24-week RBC transfusion independence were 37% and 23% respectively, with a duration of transfusion independence of about 65 weeks. So pretty promising data. We actually have an ongoing phase 3 study in MDS where these patients with low or intermediate risk MDS that are non-del(5q) and transfusion dependent, relapsed refractory to ESAs, will be evaluated to get Imtelstat versus placebo, and they would look at the primary endpoint of RBC transfusion independence. So looks like a promising drug. We'll see what happens. So some things I want to really highlight. So, don't discard ESAs, I would say, if the low dose is not working. Tweak it, increase the dose, see if adding in myeloid growth factors help. Luspatercept is an FDA-approved option for patients with low-risk MDS, ring sideroblasts, and SF3B1 mutations, which may be moving into the front line very soon. And Imtelstat appears to have a novel mechanism of activity and looks promising, but is still under investigation. So back to high-risk MDS. How am I doing on time? Let me see. Not bad. I think I'm going to finish on time. That's good. So with high-risk MDS, we do treat them still very much like AML patients. We want to right off the bat know who could be a candidate for allogeneic stem cell transplant, as allogeneic stem cell transplant is still the only curative therapy for patients with high-risk MDS. And our ESA nucleosides are really the standard of care still for patients that in the front line with high-risk MDS, and can be used as a bridge also to a stem cell transplant. And for patients that are not really candidate for stem cell transplant, we would offer them clinical trials, and there's definitely a lot of activity in this space as well. So the DNMT inhibitors actually have been shown, like azacitidine, to improve survival in MDS, and this was, a long time ago. But the drug is still sort of, an important drug and a cornerstone of treating high-risk MDS. Although decitabine actually didn't end up actually showing this overall survival benefit, some people say that maybe if in the analyzed population, an earlier cutoff might have shown the same. We don't know. We won't go there. But let's just say AZA and Dacogen are our frontline treatments for high-risk MDS. Now, there has been a lot of effort to see, well, can we improve the delivery of these hypomethylating agents by perhaps increasing their bioavailability? Or could we make it into an oral formulation, which would allow a better quality of life for our patients? And so this particular drug, which is the Inqovi, it's an oral decitabine-cytidine deaminase inhibitor. So the issue is when you give DNMT inhibitors orally, they get rapidly degraded by the enzyme cytidine deaminase, which is in the GI tract and in the liver. But if you give the drug with a cytidine deaminase inhibitor, it allows greatly improved oral bioavailability. And this is actually great because I heard today and also yesterday about patients that live so far away and they have barriers accessing their tertiary center of care. And if we can give more oral options to our patients, this is definitely a win for everybody. And so, in studies which looked at kind of comparing the drug with the IV formulation of Dacogen or subcutaneous, this is just an analysis of demethylation, which shows whether pharmacodynamically it's on target. And you can see that the oral drug actually is on target and has similar bioavailability as the IV formulations. So the responses that occurred are also standard, are very similar to when you use standard DNMT drugs. And this is actually FDA approved for treatment of high-risk MDS and is a good oral option to consider. So unfortunately, we still deal with this problem a lot of HMA failures. So in high-risk MDS, when patients have failed HMAs, it's still a very poor prognosis. We're looking at average overall survival of 3 to 4 months. So this is really dismal, and it's a tough population of patients to treat. We definitely have some activity in this space in high-risk MDS. One of the things that, this still comes up at our center. I would love to hear what other people's experience is. Occasionally, we will still discuss salvage transplant, and I think you can make these decisions on a case-to-case basis. But in this population that has failed frontline therapy, the best treatments available are obviously investigational treatments and allogeneic stem cell transplantation. Okay, so talk amongst your group on a case-by-case basis about allotransplant and a clinical trial. So I want to highlight some drugs in development which may be potentially interesting and likely on a strong regulatory path as well. So CD47 is an immune checkpoint which lies on the surface of macrophages. And we have this drug magrolimab, which is a CD47 blocking antibody that induces macrophage-mediated phagocytosis of the tumor cells. And it also seems to have synergy with azacitidine, and it upregulates these eat me signals on the surface of the tumor, or the SERP1 alpha. And so this is the phase 1 data with magrolimab and azacitidine in patients with untreated high-risk MDS, and it appears that the drug is actually very highly active if you look at TP53 wild type, but even in the TP53 mutated population, which, as we heard from Dr. Kadia, even in AML, is a very hard population to treat, it appears to actually have good activity in terms of overall response rates and CR rates. And in most patients who achieved a CR, the responses deepened over time, and 35% of transfusion-dependent patients became transfusion-independent following treatment. So if you look at actually the drug by TP53 mutation status as well, of course, those that were TP53 wild type did well, but the TP53 mutant, the separation of the line is not as dismal as you usually see. It does appear that they are responding to the treatment, and the median progression-free survival was about 11 months, and the overall survival was not reached with a median of 17 months of follow-up. So this is, so just to finish up really quickly, so it does look like it does have a high amount of activity in TP53 mutated patients as well in combination with AZA. And as early as cycle 3, it looks like there was a reduction in the allele frequency of TP53, which appears promising, and maybe it could change the trajectory of this extremely difficult to treat disease. And then, overall appears to be quite safe, no significant immune reactions. There's one interesting on-target effect, and this is because the CD47 is a little ubiquitous. It's also on the surface of red blood cells. So there is an on-target anemia that patients can see, and this kind of hemolytic anemia could cause a problem, especially early on when you start treatment. This is why they give a priming dose, followed by treatment on day 1 and 4, weekly treatment, which eventually ends up becoming a maintenance of 2 weeks. So just to keep in mind, you have to observe the patients very closely for this anemia and transfusion need in the early weeks of initiating this drug. So there's an ongoing phase 3 study which will provide additional data, of course, on magrolimab and AZA in high-risk MDS, and we're eager to see the results of it. Other immune agents that are interesting in this space, so the TIM3 antibody, sabatolimab, in combination with HMA, have also shown some durable responses in high-risk MDS and AML. And it appears also that because this is like an immune-targeting therapy, that this may actually be beneficial for those patients with more high-risk complex cytogenetics as well. And there are other CD47 targeting drugs as well in development. And Venetoclax, of course, is a very important drug, which is upcoming in MDS. We're kind of going on the back of the data that we see in AML. And 84% of patients that received Venetoclax and AZA respond to treatment, and the median time to response is very fast. So actually, this is great. You can actually tell if a patient is responding or not relatively early and continue on treatment, and the median duration of response is long, 12.4 months. And this combination appears that across the mutational spectrum, patients are responding to Venetoclax and azacitidine. And again, we have another phase 3 study here, the Verona Trial, which will assess Venetoclax and AZA in high-risk MDS. So as Dr. Kadia mentioned, the cytopenias and myelosuppression is a very significant issue with Venetoclax. And this, as you can imagine, is worse for MDS patients that are sometimes cytopenic to begin with, compared to AML patients. So the duration of dosing here is reduced to 1 to 14 days per cycle. And there are, of course, like dose reductions written into the study in case patients cannot tolerate such high doses or even 14 days duration of therapy and higher dose. Another promising agent in development in high-risk MDS are IRAK inhibitors. So the IRAK4 is actually a serine threonine kinase, which is kind of works closely with the ILR and the toll-like receptors to form the midosome complex. And the IRAK4 long isoform is overexpressed in MDS, and it correlates with a poor prognosis. And we have IRAK inhibitors that are currently in development, and this particular one seems to be the most further along, emavusertib, which has shown single-agent activity in AML as well as MDS, and the CR rates, as you can see, are quite good, and I think this requires further investigation, though. The interesting thing about IRAK4 targeting is that these drugs also have some level of FLT3 inhibition, so they do have dual activity of IRAK and FLT3 inhibition. So just to summarize very quickly, so MDS is an important cause of anemia in the elderly once you have ruled out other causes of anemia. And the clinical features, the morphologic exam by bone marrow is something that helps us make the diagnosis. And of course, we know we rule out common other causes of anemia before we give somebody a cancer diagnosis. And the major complications that we encounter are progressive cytopenias, infections as a result of that, and progression to leukemia. We have new prognostic scoring system now, the IPSSM, and I would love to hear other people's experience too using it. I've found it actually beneficial, but one of the major issues is that with this IPSSM is that some molecular classes are still not well captured even within all the different categories. ESAs are still our first line in low-risk MDS. We have del(5q) MDS responds well to lenalidomide, and we have luspatercept for the patients that have ring sideroblast, SF3B1, mutated low-risk MDS may soon move to the front line. For high-risk MDS, our hypomethylating agents, azacitidine and dacogen, are still our standard of care, and we have an oral option now, which is the decitabine cedazuridine fixed drug combination. And there are several investigational agents, and I think one of the most important one is Venetoclax, but then we also have Imtelstat, the telomerase inhibitor, magrolimab targeting CD47, sabatolimab targeting TIM3, and imavusertib, which is the IRAK4 inhibitor. And then allo stem cell transplant is still a very, very important cornerstone of treatment and our only curative option, so we should always keep that in mind. Thank you so much. I appreciate your attention and your interest, and to all the people from whom I also stole slides, and to the wonderful organizers and the audience, and really big shout out to our patients because they teach me so much more about life than anyone else. So thank you so much.